Head and neck. Having a basic understanding of the developing head and neck is crucial in correctly assessing and effectively treating tissues arising from the area. Knowing the origin of the branchial arches, dorsal aorta, and the aortic sac lead to a solid anatomical and physiological basis of knowledge. Knowing what nerves and cartilage are associated with the arches is of equal importance. For example, realizing structures within the petrotympanic fissure can be affected by manual therapy techniques, which in turn may result in a change in blood flow within the middle and inner ear, may help a tinnitus problem. Understanding the origins of the nervous system from neurulation to neuronal migration will explain the relationships between the central nervous system, the cranial nerves, and the autonomics. Being aware that sympathetics are recurrent and travel back into the brain from the upper thoracic cord is critical. Correcting the forward head posture will no doubt change hemodynamics within the cranial vault. One has to discern the following. Is it a presenting condition of this pathophysiology? Is it a red flag condition? If it is hypoxia, then what is the epidemiology? Osteonecrosis, insufficiency fracture, enthesopathy? How do I test for it? Am I targeting the correct tissues during the test? What outcomes am I looking for? Obviously, not every case has this type of disability. Focal dystonias or vertebral fixations are two examples. Some cases may partially have this etiology. For example, upper cross syndromes, forward head postures, for example. The patient may present with a red flag. If the symptoms are of recent onset, getting worse and not position dependent, be careful. Restrictions of the cervical spine of the pathological etiology contraindicate manual therapy. Patients affected should be referred to relevant medical specialists. Therefore, all patients must be examined prior to and continuously monitored during treatment of the cervical spine, lest any existing pathological condition be worsened, increasing the risk of injury. Prior to treatment, assure by test or test report that declines, Houghton's and Romberg's tests are negative. Positive tests contraindicate manual therapy. Pathological hypermobility in a segment contraindicates stretching of that segment. During treatment, patient dizziness, nausea, radiating pain, or other severe discomfort during treatment may be signs of vascular spasm, anomalous blood vessels, fractures, ruptured ligaments, instability, herniated discs, or other pathological conditions that contraindicate manual therapy. The patient should be continuously monitored for these signs, and if they appear, their therapy should be stopped immediately. Epidemiology and hypothesis testing play major roles in the assessment. Suppose a patient presents with chronic bilateral hand numbness. What's the likelihood of the problem being carpal tunnel or cervical disc or Beck minor syndrome? The history will give clues, and epidemiology will give probabilities. Start testing with the most likely hypothesis. When you start the testing, how can you tell if overpressure is applied to the correct tissue? One positive sign is that symptoms are reproduced as the overpressure is being applied. A second sign is the end range motion is increased. The response can be immediate or take a couple of days. The response can go in four directions. Better, somewhat or only temporary better, don't change, or aggravated. It should be evident that these procedures are really orthopedic or neurological tests. Your direction of therapy will be determined by the results of these tests. If the patient is better, they probably only need 1 or 2 times. Partial results will mean you're on the right track, but will have to perform more similar tests. If no change results, then reassess, and if conditions worsen, consider referring out. As a rule, I perform each procedure several times during a session. I start gently and then repeat with a mild increase of force until just before I reach the end of the patient's tolerance level. I always explain to the patient what I'm about to do and get verbal consent. During each procedure, I ask how the patient is doing and insist they give constant feedback. On repeating the procedure, I ask for consent again and again and again. The biggest factor to a successful and safe session is the patient's feedback. After all, she is really the only one who knows where the problem is and if you are affecting the correct area, and if there is an improvement, or most importantly, if it's causing pain or harm. I can't overstate the importance of a forward head posture upper cross syndrome. Any cranial nerve involvement, any tinnitus, any post-concussive syndrome, any whiplash problem, I can't overstate the importance of getting that head back. We talked about the recurrent autonomics going back, feeding the blood supply, feeding the blood vessels within the brain. Sympathetics, parasympathetic centers within, centers of the brain itself. These are all affected with the forward head posture. Just by doing the morphological change and getting that head back, upper thoracic spine, that's probably going to do more than any other procedure that you're doing right now. Again, you always have to have red flags. You always have to see the red flags. Problems with numbness down the hands, pec minor syndrome, trapezius being too tight, suboccipitals being too tight, headaches in the back. Once you can get the head back, then you stretch these muscles out, then you strengthen the inhibited groups. These problems all tend to go away. Interesting thing is once a patient understands what you're doing and are given some home exercises, they can take care of these things themselves. And I think that's best practices, and that's doing a real service for the patient.